Good morning, everyone. So, to continue the Module 5 review session, we're now going to refer to Chapter 37, which is Obstetrics and Neonatal Care. This will be broken down into multiple parts to keep you from getting too overwhelmed, I guess. So, the first part of this chapter talks about obstetrics. Let's talk about the anatomy of pregnancy. I'm going to briefly list these organs off, and we're not going to go into too much detail about these. You will be able to read those in your chapter. Ovaries, fallopian tubes, the uterus, the fetus, the cervix, the placenta, the umbilical cord, the amniotic sac, and the vagina are all parts of the anatomy of the pregnancy. Okay. We know that the ovaries generate the ovum or the egg. The egg is fertilized in the fallopian tubes. From the fallopian tubes, the ovum is transported to the uterus where it is implanted and the fetus begins development. The placenta begins to develop. This is known as the organ of pregnancy, and it allows the fetus to receive oxygen and nourishment from the mom through the one vein, and through the two arteries discharge carbon dioxide and waste products. The umbilical cord is made up of two arteries and one vein. You need to know that. The fetus obviously is the baby. The cervix, or let's talk about the amniotic sac, refers to the bag of waters. This is where the actual baby is housed inside of the uterus, and it contains 500 to 1,000 milliliters of amniotic fluid. The cervix is that part that keeps the baby where it needs to be until it's time for it to come out. It is at the neck of the uterus, okay? And so the cervix has to dilate 10 centimeters and become completely effaced or thinned in order for the baby to be delivered through the vagina. We're not getting into the prenatal period other than to say that pregnancy is divided into trimesters. Each 3-month period is known as the trimester. So month 1 to 3, which is 1 to 12 weeks, is the first trimester. Months 4 to 6, or weeks 13 to 27, or the second trimester. Months 7 to 9, weeks 28 to 40, or the third trimester. As the pregnant patient grows into her pregnancy, if you will, alterations in multiple different, if not all different body systems occur as hormones are circulated. For instance, the reproductive system. The pregnant uterus is extremely vascular and contains approximately 1/6 of the total blood volume of the mom. Mom's respiratory center, oxygen demands of the mom are increased. Her respiratory rate will increase only slightly. However, there is an increase in oxygen consumption by approximately 20%. Mom's cardiovascular system goes through some changes as well. Her maternal blood volume increases by 45%, resulting in a cardiac output increase as well. Her heart rate will increase by 10 to 15 beats a minute, and her blood pressure will slightly decrease during the first and second trimester and return to normal in the third trimester. Gastrointestinal system changes also occur. She will experience or can experience nausea and vomiting, commonly in the first trimester, known as morning sickness. And this is due to hormonal changes and the need for carbohydrates. Bloating and constipation also occur even further into her pregnancy as the fetus grows and puts pressure on the GI tract, specifically the colon. Urinary system, renal blood flow increases. The bladder, her urinary bladder is displaced superiorly and anteriorly, which puts her at a higher risk for injury to this organ. And her muscle skeletal system changes as well. Her pelvic joints are going to loosen as a result of hormonal changes, but her center of gravity is also changed as well, putting her at a higher risk for falls. Anytime we refer to the term antepartum, it means before delivery. An antepartum condition causing severe vomiting, dehydration, and electrolyte imbalance is known as hyperemesis gravidium. Hyperemesis gravidium. Women who experience hyperemesis gravidium usually occurs between the 4th and 6th weeks of pregnancy and can peak between the 9th and 13th week. This differs from typical morning sickness because they experience severe nausea and vomiting, which can lead to weight loss. It can lead to hypotension and tachycardia, all which can lead to dehydration, resulting in hypoperfusion. We'll move on to antepartum conditions that cause hemorrhage, the first of which is the spontaneous abortion, also known as the miscarriage. Vaginal bleeding before the 20th week of gestation occurs in about 20% of all pregnancies, with 50% of these cases resulting in the spontaneous abortion. The cause of this miscarriage is commonly genetics, or it can be caused by uterine abnormalities, abnormal fetal developments, infection, drugs, or maternal disease. Cramping and vaginal bleeding are usually present at 8 to 12 weeks of gestation. Mom may complain of cramp-like lower abdominal pains, moderate to severe vaginal bleeding, which might be bright red or dark red in color. She may also tell you that she experienced the passage of blood clots or tissues. Emergency care is patient dependent. You're going to provide emotional support because this can be very stressful for mom. Mom may also present with signs and symptoms of hypovolemic shock, and you would treat her accordingly. Ectopic pregnancy is one that occurs outside of the uterus. I previously stated that fertilization occurs in the fallopian tube, and the fertilized ovum is transported to the uterus where it is implanted. This is not the case with ectopic pregnancy. The fertilized egg is implanted outside of the uterus, and it may be in the fallopian tube, on the abdominal peritoneal covering, the outside wall of the uterus. It can be on an ovary or even on the cervix. As the ectopic pregnancy grows, as the fetus grows, depending on where it is located, it may rupture the fallopian tube, for instance, or even an ovary, causing maternal death. Ectopic pregnancy is the third leading cause of maternal death, and it's most common in women ages 25 to 34 years of age. Some of your assessment findings might include dull or aching type pain that is poorly localized. They may say that pain is referred to the shoulder because of blood in the abdominal cavity that's irritating the diaphragm. Vaginal bleeding can be heavy or light. Signs of shock are not unheard of in this situation. They may have an urge to defecate, and there may also be a discoloration around the navel if the rupture occurred hours earlier. Your emergency care, treat your patient accordingly as far as the shock management, and you need to get her to the hospital. Okay. Any signs of hypoperfusion, again, need to be treated as any other shock patient. Placenta previa is associated with abnormal implantation of the placenta over or near the opening of the cervix. The placenta is normally implanted at the top of portion of the uterus and posteriorly. However, with placenta previa, it can be located, it can implant itself on or over, over or near the opening of the cervix. Your book goes on to discuss total, partial, and marginal placenta previa. Your predisposing factors are also listed for you, typically seen in women greater than 35 years of age or those who have more than 2 deliveries. They may have had rapid pregnancies, okay? So a rapid succession of pregnancies. So they got pregnant back to back. They may also experience bleeding immediately after sexual intercourse during their pregnancy. The hallmark sign of placenta previa, guys, here we go, is painless vaginal bleeding. That is classic. Emergency care is going to be just as you would any other antepartum emergency patient. If your patient is showing signs of shock, you will treat them accordingly and transport immediately to a medical facility that can manage surgical obstetrical emergencies. Abruptio placentae or placenta is also known as placental abruption, and it is the premature separation of the placenta from the uterine wall prior to the birth of the baby. Small arteries in the lining between the placenta and the uterus are prone to rupture. When this happens, blood will accumulate between the placenta and the uterine wall, causing separation of the placenta from that wall. As more blood accumulates, the placenta continues to tear away. Premature separation from the placenta can cause major problems to both the fetus and the mom. And there are 2 types listed in your book, complete and partial. The hallmark sign for symptoms of abruptio placenta or vaginal bleeding with abdominal pain and tenderness. Okay. Placenta abruption usually occurs in the second half of pregnancy, and it'll be associated with vaginal bleeding and abdominal pain. Management for these patients, you need to treat them for shock accordingly and get them to the hospital that can manage surgical obstetrical emergencies. Okay. Ruptured uterus is when as the uterus enlarges, the uterine wall becomes extremely thin, especially around the cervix. It can lead to a traumatic or spontaneous rupture of the uterus itself, allowing the fetus to present outside of the uterus. A ruptured uterus results in severe maternal hemorrhage and severe fetal distress, and it requires immediate emergency surgery. Emergency care for this type of patient, you're going to follow your general guidelines for your pre-delivery emergencies. Treat them for shock regardless, and get them to the hospital that can provide surgical obstetric emergency surgery. Okay. Your antepartum seizure and hypertensive emergencies, seizures during pregnancy. Okay, it's not common. It can be caused by an increase in intracranial pressure, maternal injury, hypoxia, hypercorbia, and a list of others. Death to the mother can also result from cerebral hemorrhage, respiratory arrest, kidney failure, and circulatory collapse. In situations where you have seizures with the pregnant patient, provide emergency medical care as you would for any other patient. However, you're going to place mom on her left side with her right hip elevated, especially if she's greater than 20 weeks gestation. This is going to alleviate pressure on the right atrium, specifically the right or the superior and inferior vena cava. So make sure you put mom on her left side. Seizures in pregnant patients can be associated with hypertensive emergency eclampsia. Pregnancy-induced hypertension is defined as a blood pressure in pregnant women that is greater than 140/90 on 2 or more occasions at 6 hours apart. When generalized edema and protein in the urine are associated with the elevated blood pressure, this is defined as preeclampsia. Preeclampsia can lead to eclampsia. It says hypertensive emergencies during pregnancy are the second leading cause of maternal death in the United States. Preeclampsia was once known as toxemia. It's a common condition affecting approximately 12% of all pregnancies. It usually occurs in the last trimester of pregnancy, but can be seen as early as 6 weeks after, or can be seen as early as 6 weeks after pregnancy. With eclampsia, it's a more severe form of preeclampsia where the patient will experience unexplained coma or new onset of generalized tonic-clonic seizures. Preeclampsia is characterized primarily by high blood pressure, generalized edema, and protein in the urine. Your patient may also complain of visual disturbances, a sudden weight gain, nausea and vomiting, decreased urine output, diabetes mellitus. All of these can be found in your assessment when suspecting eclampsia or preeclampsia. Your emergency care for a patient greater than 20 weeks in gestation, you're going to administer high flow of oxygen regardless of the pulse ox reading. So I'm going to put the pregnant patient who I suspect is preeclamptic on 15 liters of oxygen via non-rebreather, regardless of what her pulse ox reading is. This is to maximize the oxygenation of the fetus, and I need to keep suction close in case mom begins to have seizure activity. Okay. Supine hypotension syndrome. So the opposite end of the spectrum, when mom's blood pressure drops. It's usually seen in the second or third trimester, and it occurs when the weight of the fetus compresses the inferior vena cava when mom is laying supine. So how do we manage this? Or why does this occur? It occurs because there's a reduce in the blood flow to the right atrium, which, as we know, decreases preload. When there's a decrease in preload, there's obviously going to be a decrease in stroke volume and in return, reducing cardiac output. Okay. How do we manage this? We put mom on her left side, okay, and we elevate her right hip about 15 degrees. And this is going to shift the weight of the fetus off of the right atrium and inferior vena cava, allowing an increase in preload and, so forth and so on. Pre-delivery emergencies. Okay. When it talks about pre-delivery emergencies, your primary assessment is going to be basically the same thing as with any other patient. However, when we get to our secondary assessment, we need to be more thorough in our questioning. We need to ask, how many pregnancies have you experienced? How many pregnancies resulted in live birth? Were those deliveries vaginal or by cesarean? Have you had any complications with any of these births? And what was the last day of your menstrual period? When reporting this information to the hospital, guys, we refer to what's called as gravida and para. Gravida refers to the number of times mom has been pregnant. If I say the term preemie or preemie gravida, that means this is her first pregnancy. Para refers to the number of times an individual has completed the pregnancy, whether the birth was a live delivery, baby was alive, or baby was stillborn. So I have a patient and she tells me she's been pregnant 4 times and she's given birth 3 times. So that I'll refer to the hospital. My patient is gravida 4, para 3. She's been pregnant 4 times and has delivered 3 times. Okay? All right. Okay. Before we get any further, I'm going to end this portion of the session and come back with part 2.